Hello everyone. I am Dr. Utsav Bansal and this is my SOT session for the NEET-PG August 2025 Ophthalmology recall questions. As always, we cannot stress enough on the importance of recall questions. There were a total of 6 ophthalmology questions asked in this NEET. Yes, the number was a little less than usual. Usually we get around 8 to 10 questions, but nonetheless, what was even more surprising was that none of the questions were difficult. All of them were somewhere related to topics which we accept, uh, which we which we expect, apart from one topic. So I can say 5 out of 6 questions were pretty easy. Only one question was slightly difficult and not too difficult. It was a known question, just it made you think a little more. That's what we will discuss. That's what we will do. Remember, these are recall questions. So there may be little differences between what had actually come and what has been told to us by you wonderful students. So please mind that fact. If you find any discrepancy, please feel free to comment and we will be able to check it out. Okay, so let's start with the first question that was asked. The first question is, a patient with bullous keratopathy, that means cornea question, has corneal gut data in the other eye. What is the most likely diagnosis? So now, seemingly, this is something which we have not studied, but if we pay attention to our class, we have studied one word in this question that clearly gives us the diagnosis. Only one word, one answer, done. You need not have spent more than 10 seconds on this question. So, what is the word I am looking at? Gut data. Yes, if you have ever read the topic corneal dystrophy, then you may have come across this word gut data, and that would have been the answer. If not, let me remind you by showing you a screenshot of your class. Yes, see, corneal gut data has been marked. Corneal gut data is found in Fuchs endothelial dystrophy. Right, corneal dystrophy has been presented to you in this way only, where we have written the keywords because that is what is important to learn, and based on that, questions are asked. So, a patient presents with bullous keratopathy and has corneal gut data in the other eye. What is the most likely diagnosis? Through our teachings, we should have known the answer pretty clearly as Fuchs endothelial dystrophy. If you did not remember this, then how could we have ruled out, let's say, keratoconus? Keratoconus is a very common topic that we have studied, cone-shaped cornea. In keratoconus, we have studied important signs like Munson's sign. Yes, we have studied signs like Vogt's striae, and a lot of other signs. Yes, I'll not go into the detail. But have we ever heard corneal gut data there? Yes, I don't think so, because this is a common topic. Secondly, herpes keratitis. Herpes keratitis, all of us know the two famous names: dendritic ulcer, geographic ulcer. Along with that, there are various others. What are the various other things? Necrotizing disciform keratitis, endothelial keratitis, blah, blah, blah. But nothing is close to corneal gut data. Trachoma, all of us know it is a conjunctival lesion. Yes, it is one of the most common conjunctivitis, which is affecting endemically. Yes. So we know the answer could have been Fuchs endothelial dystrophy, either directly or indirectly. We just have to apply our mind. Now, I've shown you the screenshot. Now let us just quickly revise what is Fuchs endothelial dystrophy. As all corneal dystrophies, this is a bilateral and progressive disease. But please remember, this is more common in females who are age greater than 50 years. That's the characteristic, the age, right? Please also remember, this is the most common endothelial corneal dystrophy. Also remember one very important question for the future. This is the most common indication in the eye for keratoplasty. Keratoplasty means corneal transplantation. Yes, because these are opacifying disorders. If you are not able to treat them and you are not able to treat them, the only treatment left is keratoplasty. Now, if we talk about the clinical features or the signs or the stages in brief, I can say it starts with the formation of asymptomatic gut data. Now, sir, why do gut data form? What are gut data? So I hope you remember through our class, gut data are wart-like excrescences, or I can say gut data are, these are focal outgrowths of Descemet's membrane. Why do they form? This is genetic predisposition. What is the genetic predisposition? We know that at least two genes are responsible for this. What are the two genes which we at least know? TCF gene and collagen 8A2 gene. Okay, these are the two genes that we at least know. Yes. Now, after asymptomatic gut data are formed, then what happens? Then starts corneal decompensation. Endothelial cell loss, because it is an endothelial dystrophy. So corneal decompensation due to endothelial cell loss. Now, when endothelial cell loss will occur, when corneal decompensation will occur, we know endothelium acts as a barrier to pump out the fluid from the cornea to maintain corneal transparency. So what will occur? Fluid will not be pumped out, corneal edema will occur. Corneal edema will lead to diminution of vision. And finally, if it advances to the final stage, then we say what will start happening? Bullous keratopathy. That means now the epithelium will also be affected, bullae form, and then they burst, and then this becomes a painful condition. So this is the end stage. So now if you understand, this is what is given in the question. In one eye, there is already bullous keratopathy. So in one eye, already FED, Fuchs endothelial dystrophy, has progressed to the last stage. But in the other eye, it is still asymptomatic gut data, because this is a bilateral disease. Bilateral but asymmetric. That's all. Yes. Are we clear about the clinical features? If not, then let us see these two photographs. The first photograph on the left is a microscopic corneal photograph showing gut data, and the second photograph is a slit lamp photograph showing bullous keratopathy. Let us see what is gut data. If we are able to see, this is my descemetes, but in between we will see there are empty spaces and there are excrescences, focal excrescences, which have been formed in between. Yes, so all these are gut data. Can you see? So something like this. This is how we show it if we draw a line diagram. So the descemetes membrane forms focal excrescences into the endothelium, and it appears like this. Am I clear? Now, let us see the other image on the right, the slit lamp image. If we can focus into the center of the cornea, I know it is difficult, but try to focus. We will be able to see some kind of round, oval bullae. Yes? Can you make out? Because of the opacity they are causing. I am tracing them for you. And this is bullous keratopathy. This is how you can see case of bullous keratopathy: opacification of the corneal epithelium, formation of bullae. These bullae are fluid filled cysts. They will burst, and after bursting, obviously there will be pain, because this will lead to epithelial aberrations, and lots of them. Am I clear about this? Now, what is the diagnosis and treatment of Fuchs endothelial dystrophy? Diagnosis. See, diagnosis, first of all, in earliest case is based on slit lamp examination, because it is asymptomatic gut formation. So slit lamp examination will be able to show you some kind of abnormalities into the corneal endothelium. Secondly, what can you do? You can obviously do specular microscopy. Specular microscopy is for endothelial cell count. We know it is an endothelial dystrophy. And thirdly, because we know that there will be corneal edema, what can we do? Pachymetry. Yes, so these are the diagnostic tools, but usually we end up doing one and two, and that is enough. Pachymetry is usually not needed. How to treat it? So what is the treatment? In symptomatic cases, early on, we can give hypertonic saline. Symptomatic cases means when corneal edema started to occur, diminution of vision is occurring. So because there is corneal edema, we are trying to give hypertonic saline 5% to dehydrate the cornea. Along with that, we give lubricants to keep the corneal surface moist. But both these are actually not going to treat. So actual treatment, if we say, is only one, that is DMEK, keratoplasty. Yes or no? Descemetes membrane endothelial keratoplasty. That is why we said this is the most common indication for keratoplasty. Are we clear about this? Let us quickly revise corneal dystrophies through this chart, the same chart that has been shown to you in your videos. There are 4 types of corneal dystrophies depending upon the layer that is affected: epithelial, Bowman layer, stromal, or endothelial. Epithelial, please remember Kogan's name. Kogan's is the most common. That is what I have done. I have given a keyword for almost each type of corneal dystrophy, because these are the keywords that are asked. As we will see in Fuchs endothelial dystrophy, the keyword only given in this table is cornea gut data, and that is what is responsible for us being able to answer this question that was asked in this NEET-PG 2025 examination, right? Going back, epithelial Coggins is the most common. Meesmann is non-progressive. Usually all the dystrophies are progressive, but Meesmann is non-progressive. Lish epithelial dystrophy. Almost all are autosomal dominant, but Lish can be X-linked dominant also. So these are the keywords which we want to remember. Similarly, now Bowman's layer is very rare. So nobody asks, or not commonly asked. Let's not say nobody asks. Stromal is very commonly asked. It is very common. So in stromal, the most common name is lattice. Lattice may please remember there is amyloid deposit, and amyloid deposit is stained by Congo red. Yes. Similarly, there is granular. In granular, there is hyaline deposit. Hyaline is stained by Mason trichrome stain. And remember, macular, at least macular is autosomal recessive because it is not autosomal dominant. It becomes a question, and it is the least common corneal dystrophy. So this is the way we can remember quickly corneal dystrophy. It is a topic which has lots of names. That way, this has been given to you in a tabular form so that you don't make mistakes, and a keyword can help you reach the diagnosis in a question. All right, guys, let us move on to the second question that was asked in this NEET-PG 2025 August attempt. A 15-year-old girl, okay, came with painless swelling. Painless, gradually progressed over the past 1 year. What is the diagnosis? So they have asked you a diagnosis based on an image and a question. So what does the image show us? The image shows us a painless swelling. Okay, this is the swelling. So I can say basically it is present in the superotemporal area. A swelling is being shown present in the superotemporal area. Yes. Now, if there is a swelling around the eye, what it should cause? Try to think about the topic. It should cause some kind of, or it should apply some kind of force on the eye. When it applies force on the eye, it will push the eye. Push the eye means it should cause some kind of proptosis. Am I clear here? So indirectly, this question is on proptosis. So let us focus our mind toward proptosis and let us see this. This is a screenshot from the videos that we have been taught. You will see that proptosis, if it is unilateral proptosis can be of two types, axial and abaxial. Axial means when the eye will protrude out straight. Abaxial means it will go left, right, up and down. So if we see axial proptosis, causes are orbital cellulitis, cavernous sinus thrombosis, optic nerve glioma, and cavernous hemangioma. Now, cavernous hemangioma. Hemangioma is supposed to cause axial proptosis. Axial proptosis can be caused by something which is retro, or retro means behind the eye. Yes, it cannot be on the side of the eye. If it is on the side of the eye, it will push abaxially. So that means hemangioma is present retroorbital, behind the eye. So hemangioma cannot be the answer. Secondly, hemangioma is of two types, capillary hemangioma, cavernous hemangioma. One will occur in an infant, one will occur in an adult. But here the age group given is 15 years for the past 1 year. That means the age of onset was 14 years. Yes. So hemangioma is ruled out through both the things. Now let us move on to abaxial. In abaxial, if we see the first and the second, lacrimal gland tumor or mass, dermoid cyst. Both of them are similar. That's what we will see. Both of them cause abaxial downward and medial protrusion. Why are they causing downward and medial protrusion? If this is my eye, this is my nose. If this is the mass, where will it push? It will push down and it will push in. That means lacrimal gland tumor and dermoid cyst both are present superotemporal. Am I clear here? Yes. So that means if we remembered about proptosis, osteoma does not occur here. Yes, this is not a common site for osteoma, so that should be ruled out. So that means the diagnosis could have been between either a lacrimal gland mass or a dermoid cyst of the orbit. These are the only two diagnoses possible in this question. Now, based on an image, how to find out whether it is a lacrimal gland mass or a dermoid cyst? So that's what I'm trying to tell you. Based on an image, you cannot go further. Based on an image, we could only find out that it is a supratemporal area. Proptosis will occur abaxially, down and in, medially and down. And due to that, there can be only two causes, lacrimal gland mass and dermoid cyst of the orbit. Now, the rest of the answer depends on the question. What is the age? Lacrimal gland mass, dermoid cyst. What is the swelling? Painless, painful. What is the progression? So if we can differentiate between these two, the main difference is of age. Orbital dermoid cyst, we know this will start to form somewhere before 20 years of age. So it forms in the first to second decade of life. But lacrimal gland mass usually forms in old age, fourth, fifth decade of life. That is the biggest key differentiator. Secondly, progression. We know orbital dermoid cyst, this is benign. Because it is benign, we know it is very slow progression. But in the question, it is just given lacrimal gland mass. Lacrimal gland mass can either be benign or it can be malignant. They have not specified. What is the most common benign tumor of the lacrimal gland? Pleomorphic adenoma. What is the most common malignant? Adenocystic carcinoma. Yes. So we know it can be benign, it can be malignant. Because it can be both benign and malignant, it can either be slow or it can be very fast progression. It can be acute progression. So that means the question is not giving us enough to justify a lacrimal gland mass because it is a broad diagnosis. Also age. Finally, as I said, we cannot differentiate between the two conditions based on a photograph. We need to do imaging. On imaging, you will see a well-defined cystic swelling, but you will see a well-defined lobulated mass, and it will be hyperintense on T2 MRI if it is a lacrimal gland mass, preferable, mostly pleomorphic adenoma. That's what we are talking about here. Yes, benign with benign. Am I clear about this? I hope there is no confusion. So the answer in this case was dermoid cyst. This is the only question where you could have used your head a little. That's what I said. 5 out of the 6 questions were pretty direct. Only one question was where you could have used a little bit of your brain if you were confused. Though still, I would have assumed that it was a 50-50 question. It was not a 25 question. You could have ruled out 2 easy options. It was, if a confusion, only between option A and option B. The topic is proptosis. As you would remember, in 2024, in 2023, proptosis and orbit questions have been asked regularly. So the trend is pretty clear that they are asking you orbit questions now, right? Dermoid cyst of the limbus, limbal dermoid cyst was asked last year. So they are asking questions on the same track. Topics often do not change a lot. All right, moving on, please. Next, third question. Indication of the given procedure. I think this was the easiest question. You just had to see the image, you just had to answer. So what is the image? What is the image showing you? It is showing you a cornea with some kind of a ring in it. What is this? That's all you need to identify. So this is Intacs. Intacs. What is the full form of Intacs? Intracorneal stromal ring segments. That's it. You needed to answer. Do you know the answer? Yes, all of us know the answer. The answer is keratoconus. Why does it act or how does it act? See, this acts by flattening of the cornea. That is what is being taught to you. There are 2 ring segments, as you can see in the image. I'll color them more red for you. The 2 ring segments, they are pulling the cornea out. Because they are pulling the cornea out, they are flattening the cornea. So what are the indications where you need to flatten the cornea? You need to flatten the cornea in 2 things. Number 1, you need to flatten the cornea in myopia to decrease the corneal curvature, because when you decrease the corneal curvature, you decrease the corneal power. And secondly, keratoconus, because in keratoconus, we know that the cornea has become cone shape. We want to flatten it out. This should be the normal cornea, but in this case, now we have a protrusion. So you want to pull it and we want to flatten the cornea. So both these are common indications of intracorneal stromal ring segments or Intacs surgery. This image has been asked previously also. This image has been repeated. This is kind of a question which is repeat, though just the way of asking the question has been changed. Right, guys? Done. Now, this is a larger image. I hope you can see there is no confusion in this. Now, this image I like to show you because this was a new option. For the first time, I saw this option in a question in NEET-PG, keratoglobus, corneal dystrophy, all of us know. But what is Vogt's limbal girdle? Because this was an option which was a new option. I'm showing you the photograph. Option C, Vogt limbal girdle. So this is Vogt's limbal girdle. This is an age-related degeneration, just like arcus senilis. But unlike arcus senilis is 360 degree. This is moon-shaped on both sides, nasal and temporal. So moon-shaped degeneration appearing whitish in color, it is called as Vogt's limbal girdle. It occurs on both sides, nasal and temporal. So just a new photograph for you if ever it comes. All right. Now, moving on, please. To the next question, question number 4, very easy question again. Which of the following statements regarding orbital cellulitis is true? Orbital cellulitis question. Either you could have considered it in anatomy question or any NT question or an ophthalmology question. I think orbital cellulitis is a topic which encompasses or crosses all the three subjects. But I think this was a pretty easy ophthalmology question. So let us read. Option A, inflammation is restricted anterior to the orbital wall. So we know there are two types of cellulitis, preseptal and orbital. Preseptal is anterior, whereas orbital cellulitis is called when it goes posterior to the orbital wall or the orbital septum. So we know this is wrong. This is not true. Option B, ethmoidal sinusitis is the most common source of infection in all age groups. So see, I know that orbital cellulitis is an extension of paranasal sinusitis, and the most common is ethmoidal sinusitis. Do I know this? Yes or no? See, the orbital cellulitis, this is a screenshot again, most commonly occurs from extension of paranasal sinuses, most common from ethmoid sinus. We are pretty clearly writing it. Ethmoidal sinusitis is the most common cause. It is written twice. But the only confusion in this line was in all age groups. Okay, let us read the third. Let us try to rule out. Topical broad spectrum antibiotics are the first line of management. Obviously, all of us know it is wrong. Topical antibiotics cannot be the first line of management of orbital cellulitis. You have to give oral antibiotics at least. This is systemic. Yes. Then option D, patient presents with proptosis, okay, blurring of vision, normal pupillary and ocular movements. Now, do you know this? If you knew this, you know this is wrong, and that is why option B is the true option. But if you didn't know this, let us see again. Another screenshot. Initially, there is eyelid edema with pain with inability to open the eye. This is preseptal cellulitis. But once the inflammation, the infection crosses posterior to the orbital septum into posterior to the orbital wall, what happens? Orbital cellulitis, which is characterized by proptosis given in the question, but along with that, limitation of eye movement called as ophthalmoplegia. So that's the main difference. That is where we wanted to focus. That is what was given wrongly in option D. In option D, it is written normal pupillary and ocular movements. The ocular movements are severely restricted. That is basically clinically how we differentiate between preseptal cellulitis and orbital cellulitis. There will be swelling in both cases. Yes, that is not the inability to open the eye will be there. But if the eye is moving, we are sure it is preseptal. If the eye is not able to perform any ocular movement, then we know it is orbital cellulitis. It is a dangerous infection now. I hope we are clear about this. Yes, let us quickly differentiate between preseptal cellulitis and orbital cellulitis based on the table on the screen. Preseptal cellulitis is unlikely to have complications, as I just said, but we are afraid of orbital cellulitis because it can cause brain abscess and loss of vision. Preseptal cellulitis is usually due to trauma due to external sources, but orbital cellulitis is usually associated with paranasal sinusitis. That is why we need to give oral antibiotics. The most common organisms are listed on the screen. They are both same in both the cellulitis, preseptal as well as orbital. Now, clinical feature-wise, eyelid swelling is common in preseptal and orbital both. Again, as I said just now, pain will be there in both. Yes. Now, pain with extraocular movement will only be there in orbital cellulitis. Now, proptosis will only be there in orbital cellulitis. Ophthalmoplegia will only be there in orbital cellulitis. Vision impairment, again, only orbital cellulitis. Chemosis, again, only orbital cellulitis. So, all these things are only present in orbital cellulitis. That is what we want to remember. If it is preseptal, there will only be eyelid edema and pain, and due to edema, there will be inability to open the eye. Apart from that, if there is anything else, all that points towards the case of orbital cellulitis. And when we say anything else, it is proptosis, it is ophthalmoplegia, this is vision impairment. These are the three main things. I hope we are clear about the differentiation between orbital cellulitis and a case of preseptal cellulitis. Moving on, please. Next question, question number 5, asked in the NEET-PG 2025 August session. A 65-year-old male came with complaints of decrease in vision. Okay, 65, decrease in vision. There were white deposits on the anterior lens surface. I think that's the key line here. White deposits on the anterior lens surface seen during slit lamp examination. What is the diagnosis? I see the photograph. I see the question. I say don't read the question. The question is absolutely tremendously useless. We don't need to read this question at all. The image, it's an image-based question. You see the image, you know the answer. Yes, you know the answer. The answer is pseudoexfoliation syndrome. I think this is a spot diagnosis. If you don't remember what this is, then let us see. This is target sign. This is Fuchs. Target sign is deposition of pseudoexfoliative material on the anterior surface of lens. That is what they have written. White deposits on the anterior lens surface. And the second sign in pseudoexfoliation syndrome is called as Fuchs, when there is white deposit, pseudoexfoliative material deposit on the pupillary margin. These are the two characteristic photographs you have been shown again and again in all the videos, in all the revisions, and these are the images which have helped you answer this question. Now, there is some confusion. I don't know if there is. Some students messaged me saying, sir, there was an image of Fuchs in the examination, but majority of you said there was the image of target sign, or sent me the image of target sign. So was it an image of target sign or Fuchs or an image showing both? I don't know. But whatever was there, you could have solved it. As simple as that. There is no confusion in this. Pseudoexfoliation syndrome, please remember, this is the most common secondary open angle glaucoma. Right, guys? I hope we are clear about this. There is no confusion about this. Glaucoma flecken is a type of cataract that is found in angle closure glaucoma. Iritis with pupillary deposits. No, I don't know that. Anterior capsule opacification can occur in post-cataract surgery cases, but that will be very different from what it is looking like, because it will show us a IOL. We cannot see any IOL in this photograph on the screen. All right, guys. Now, moving on to the last question. Regarding different grades of binocular single vision, which of the following is correct? Okay, I think again, a very easy question. I think a question which even probably you could have done it if you have not read Squint. Yes. So figure 1 describes simultaneous macular perception and figure 2 describes fusion. Okay. So basically what they are asking you is binocular single vision grades. So what are the grades of binocular single vision? Let us first there. Grade 1, grade 2, grade 3. Grade 1 is simultaneous macular perception, grade 2 is fusion, and grade 3 is stereopsis. Right? So this is figure 1, this is figure 2. It's already written here, I should cut this. Nonetheless, in figure 1, what we can see? In figure 1, we can see a hut, and in the other eye, we can see a dog. But when we see together, we see a dog in a hut. Because both the eyes are receiving the signal together, they are able to see both the things together. So this is SMP. When two different stimuli given in each eye, but when looking through both the eye, both of them are visible together because there is simultaneous macular perception. Now, fusion, second image. In the second image, you see in one eye and in the second eye. In the second eye, you see that there is a carrot, and in the first eye, you see there is no mouth or something like that. But when you see together, you see that there is a rabbit with a carrot, because both the images, even though similar images, partially deficient, they fuse together to give you the complete image, right? So that is what it is. What is stereopsis? Stereopsis is depth perception. When we see the same object through two different angles, we are able to judge the depth, and that is stereopsis. So I think the answer is pretty clear. Option A, figure 1 describes SMP and figure 2 describes fusion. If you don't remember this, just look at this. Grade 1, simultaneous macular perception. One lion, one cage, but because both of the eyes are receiving the signal at the same time, even though different signals, we will be able to see a lion in a cage. Let's see this. Grade 2, figure 2, fusion. In grade 2, we see a house without a tree on the right side, and we see a house without a tree on the left side. But ultimately, when we see a house with both the trees, because similar image is getting fused. So deficiency in one image and deficiency in second image, both of them are getting completed by the other eye, and that's called fusion. In step grade 3, I can say, in grade 3, which is called stereopsis, what we have tried to show in this image, obviously it's a 2D paper or a 2D screen, 3D is difficult, but we have tried to show that this is a matka, a pot. We are looking from one angle, we are looking from another angle. When you from different angles, our brain is able to see the image as a 3D, because it is able to get depth based on the angular projections onto the retina. That is grade 3 stereopsis. So it was a pretty simple question. Again, I will hope so. Figure 1 describes SMP and figure 2 describes fusion. So as we could see, there were a total of 6 questions. 2 questions were from cornea. 2 questions were from orbit. One question was from squint and one question was from glaucoma. Yes, it was a little how do you say, a little uncommon in terms of the distribution. There were no questions from retina, there were no questions from lens or from neuro-ophthalmology, but still a very easy paper. Yes, as I said, apart from the question on lacrimal gland mass compared to orbital dermoid cyst, all of them were pretty direct questions. There was no confusion, or there should have been no confusion. Cornea, what are the topics? Fuchs endothelial dystrophy, or if we go, we can say corneal dystrophy. The second one was an image-based question on Intacs. I'm just listing them down for you so that you can understand that they're very easy questions. On orbit, the question was on orbital cellulitis. Pretty easy again. And the only difficult question per se was on proptosis. But again, this was the direct question which you could have solved from the class. On squint, the question was from binocular single vision, probably the easiest question they could have asked from squint. And on glaucoma, it was a exact direct repeat on PXF, pseudoexfoliation glaucoma. Right, guys? Keep studying, keep making lists of your recall questions, because as we are consistently seeing, the topics are getting repeated. There are no new topics. I can only teach so much. The examiners can only ask so much, at least from undergraduates who are appearing for their pre-PG examination. So please do not get lost into a vast sea of information. Always try to focus on the most commonly asked, on the important topics, and you shall succeed. The NEET-PG race is over, but the INI-CET race is still on. Try to focus on that. If you think you are not satisfied with the result that you are achieving in your NEET-PG, nothing is impossible. Impossible itself is saying I am possible. Right, guys? Thank you. Have a good time. Best of luck.